Good morning, everybody.
Good morning.
How are you today? That's great. That's awesome. By the way, I'm not just saying hello to all of you here, but we're doing this live stream today, and that's just something that we adopted last year. And last year we had some people on there, and this year we have almost triple the amount of people that registered to watch this today. So we're very glad about this, and I just want to thank all of them for being here as well. And I want to thank you all too. For those that do not know by now, my name is Stuart Schlossman, and I too have MS, and we're here because we put together MS Views and News, and we're providing this as a patient advocacy organization to provide something that nobody else is providing, and that is every aspect about multiple sclerosis you can learn from our programs or on our YouTube channel. It's not just about the medications, it's everything that you need to know about MS, and that is what we're bringing to you. Next, as you can see on these screens, we are very fortunate. We have all these different sponsors, and I want to thank them, and I hope that you all could thank them as well. A round of applause, please, for all those that gave us the dollars to do today's program. We have Sanofi, Biogen, Novartis, Teva, Mallinckrodt, Celgene, Genentech, and again, I want to thank them, and I hope that you all appreciate all that they're doing for us, because they're not just doing it for us, but as they're doing for us, it's enabling us to do for all of you. So again, thanks. All right, our next speaker is a very infamous doctor from Central Florida. His name is Dr. Justin Koenitzer. He's a clinical psychologist with neuropsychology background specialty. He's had 9 years in the field of clinical neuropsychology. He's affiliated with the Orlando VA, all right? Dr. Koenitzer has several published abstracts and professional presentations related to assessment of neurocognitive disorders, as well as olfaction and neurodegenerative disorder. Tongue twister. Dr. Koenitzer's clinical and research interests center on assessment and treatment of neurocognitive disorder to include traumatic brain injury, various neurodegenerative diseases, and multiple sclerosis. Let's welcome Dr. Koenitzer. He's going to come running down, right? He's going to jump up on the stage? No? Okay. Great, thank you. Come on up. Great, you got 30 minutes. Your timer is right there. Oh, good.
Okay, well, I guess I don't need to say welcome because you're all here already. You may have had this question asked of you already, but I'd like a show of hands real quick. How many folks here, this is your first MS Symposium with this particular group? Raise your hand, and the lights are in my eyes here so I can get a good sense. There's only about a handful. So most of you folks are returning folks, right? Okay, so what I'm going to do is cover something that I hope you have not already experienced in one of our other talks. I don't believe you have, with me at least. It's the first time I'm going to talk about the psychological aspects of pain in MS and psychological behavioral treatment options. So non-medical options, the pharmacological or medical options, we're going to leave to Dr. Boster and Nagroski to talk about, and they probably already have to some extent with respect to pain. I have a limited time, and this is a big topic, okay? So here's what we're going to cover in 30 minutes, all right? What is pain? Various different pain types. And pain in MS. And finally, we'll get into psychological and behavioral interventions for pain. Now again, we could probably spend 30 minutes on each one of these topics, and I'm going to talk pretty quick in the beginning just to orient you, give you a background, and then I'll try to slow down when we get a little bit more into the treatment interventions piece. So what is pain? Okay, you all probably know what pain is, but it's hard to put into words. The International Association for the Study of Pain gives us this definition, and take a look for a minute. I don't like to read from slides during these things, but you can read from your seat, and I'll throw some emphasis here on certain parts. In particular, pain is an unpleasant sensory and emotional experience, and I think that is crucial to understand pain as both sensory and emotional. According to this definition, it's a widely accepted definition. We think of pain as having two main parts. Okay, the sensory piece, and I'm going to use an example throughout here talking about a knife to your arm. Excuse that example, but it's the quickest one to make you aware of the sensory aspect of pain. Okay, and then the emotional experience colors in or fills in the full pain experience that humans have. If we stick a knife in your arm and ask you to rate the pain, you may say, oh my gosh, that's a 10 out of 10, right? If we stick a needle in your arm and ask you to rate that pain on a pain scale, you may say, oh my gosh, that's a 7 out of 10. Okay? Now, if we add in the emotional aspect that you're not used to thinking about, you can get a 7 out of 10 from a needle in your arm up to an 8 out of 10 or down to a 5 out of 10, depending on how we're tweaking that emotional or affective piece. So that's what we're going to get into today. Okay. There has been a whole lot of research over a whole lot of years to try to understand pain generally. Forget about MS pain for a minute. And I'm going to spare you all of the research and bring you quickly up to current day. Current day, we like to think about pain as biopsychosocial. Okay, in other words, meaning all of these three aspects are part of pain, and pain can be considered as a function of all three working together. So that middle piece of this graphic here, we might say, is your ultimate experience of pain, how you'd rate it. It's got the biological piece, that's the knife or the needle going into your arm, right? And it has psychological aspects to it, and even, believe it or not, some social aspects to it. We're going to get into those in a little bit more detail here. Quick example to illustrate the point that pain is more than just the sensory experience. It's more than just the needle in your arm. There is not a one-to-one relationship between the needle in your arm and your experience of pain. That's the way we used to think about it. Everybody would rate pain the same way if we get the same needle in the same place in your arm. But it's not true. We all have different ratings of pain. So a way to understand this is to think about pain like this. There is somewhere out in your body, and those long fibers on the screen there represent nerves. So one of your nerves gets stimulated in a typically painful way, and the stimulus runs all the way up into your brain, and in your brain it's received, and it gives you the experience of pain, right? That's what we think about pain. In the biopsychosocial model of pain, we understand that other aspects of your biology can influence pain, aspects that aren't related to where the needle is in your arm. For example, how many people remember an experience of pain that they've had where after the immediate insult of the pain, they go and they grab their arm or grab their leg around the site, right? And what do you typically do? Squeeze it, I heard, right? You squeeze around, you squeeze, right? And it's an automatic behavior. You don't even think about it, but you do it. Why do you do it? Makes you feel better, exactly. So we have learned that even with that same needle in the arm, which is represented there by the red dot, the pain stimulus, you can do other things in areas surrounding that site, like squeezing your arm, stimulating other pain-related and sensory-related neurons or nerve cells in that immediate vicinity that are going to, when you watch the illustration here, influence the pain signal as it goes up and kind of serve to block it, right? Now, squeezing your arm after you get a needle prick or after you bump your leg isn't necessarily going to make the pain go away completely so that you don't experience pain, but it does have an influence. It's intuitive. You grab your arm, you rub it, you squeeze it, and it tends to make that immediate intensity of pain go down a little bit, right? So that's some more support for this idea of other ways to modify pain. It's not just the pain signal itself. And then finally, this is really what we're going to focus on, is something that we refer to as top-down processing. And by top-down, I just mean from your brain down, out through the rest of your body. Information in your brain, your mood, your state of arousal, your history, your background, your expectations about the pain. Are you going in and getting a flu shot and you know it's going to be quick and easy versus someone coming up from behind you and sticking you with the needle? All of these factors actually matter a good deal as to how you're going to experience the pain. So in this final model, let's say there are psychological variables up at the top of your brain that are going to come down and beat that pain signal and not allow it to reach your brain the same way that it would if we just came and stuck your arm with a needle. Is this making sense so far? This is a very basic version of generic pain experience and the variables related. I like to think about it this way. I like to think about a pain gauge, and I like to think about pain having dials, okay? And here, this bottom up, referring to your body, your arms, your legs, pain signals coming from those areas, maybe a spasm in your leg or your arm, or some type of burning sensation in your feet, come up to your brain and get experienced. We can't really change that dial too much, can we? It's biological, it's physiological, there's not much we can do other than those medicines and things like that. On the other side of the house, though, remember, pain is a sensory and emotional experience from that definition. We have another dial that we can turn and have a little bit more power to control, and that's what we refer to as the top-down dial. All of those factors in your brain that I mentioned, your mood states, your expectations, your personality, and even your social circles, they all influence that top-down dial. And the goal with behavioral psychological interventions for pain and MS is not to get rid of the pain completely. There's no drug that will do that. There's no behavioral intervention that will do that. But if you can follow me and accept that if we can turn that dial down and get our pain from a 7 out of 10 down to maybe a 4 out of 10, wouldn't that be better? Wouldn't that be better? Okay, and we can get out and maybe do something we couldn't otherwise done if we were hanging on a 7. And that's the real goal. I just threw in here the sensory is the bottom-up stuff, and the affective, that's another term for emotional and expectations kind of stuff. Okay? Pain types, I'm going to race through this, guys, in the interest of getting you more to the treatment side of the house. But in order to talk about treatment, we have to have a context. I'm assuming most of you know a lot about this, but we'll run through it quickly to get you oriented here. Pain can be classified in many different ways, and is. Most grossly, pain is referred to as acute versus chronic. Acute is usually a sharp, very transient, quick type of pain that usually hurts real bad. Okay, it's more intense, and chronic is a longer lasting type pain that may be a little bit more dull, may not be as sharp, you don't experience it the same typically. A big distinction also in pain classification is nociceptive pain, if you've heard or read about that word, versus neuropathic pain. And if you read through this, neuropathic pain is probably the pain that you all identify with more regularly, right? Described as burning, tingling, prickling, electric shock, stabbing-like pain, okay? Neuropathic pain deals with nerve damage, whereas nociceptive pain refers to damage done to tissues or surrounding areas. And then finally here, psychogenic pain. Now, I always want to stop here. When a psychologist gets up on the stage in a medical context, they see the word psychogenic pain, people go running for the doors and say, "It's not all in my head, doc. Trust me, this pain is real." And I know it's real. I really do. And so psychogenic pain does not refer to it's all in your head, it's a psychological pain. No, it simply refers to those psychological aspects of pain that I demonstrated in the beginning in the model that we're beginning to accept, the biopsychosocial model of pain. That psychological variables have an influence on your ultimate pain perception, and a pretty significant one. So that's all we're saying there. A couple of more things to talk about with pain classification. Headache usually gets its own category, right? It's significant enough to talk about on itself. There are a couple of main types of headaches that we see commonly: migraines, cluster headaches, and tension headaches. And so we need to address that and treat that separately. And then we can talk about pain in terms of its location. This is obvious stuff for you. Is it back pain? Is it chest pain? Is it the MS hug that we might experience, that location around in the midsection there? And I'm going to skip number 7 in the interest of time. It's a way to kind of classify pain as a syndrome when it happens in multiple locations and collectively together seems to appear in a syndrome. Let's talk a little bit about pain in MS. What does the research say? Where do you fit in here? Pain in MS. So previous estimates in the research give us this wide swath of lifetime prevalence of pain in people with MS, from anywhere from 29 to 86% across a series of studies. This wasn't too long ago, but it's older research. That's a lot. And you know what else? If I were sitting in your seat there and maybe newly diagnosed or reflecting back on the patterns of pain you might experience, I'd say, whoa, that doesn't make sense to me. How could a research study come up with 86% of lifetime prevalence of pain in MS and another one say it's only 29%? Short story is, it really depends on how the research asked the question to the people involved in the research, and it really has to do with what type of pain were they assessing? Were they asking, did the pain happen a month ago? Did it happen a year ago? And different aspects like that. Just as we reviewed the different types of pain, you can imagine any one research study could focus on any type of pain. And so that's what we have determined to account for all of those differences in studies. Well, more recently, more powerful studies, they're referred to as meta-analytic studies in the research, they take all of the data from all those various studies, okay, and they put them all together in a pool. Much more powerful study to say, I'm going to look at 10 studies and pull them all together, and here's your answer. Through meta-analytic studies, we find, and this is very recent, I think it's 2015, about 63% of individuals with MS report pain at some point in their disease course. That's a lot. Significantly more than half of folks will experience pain. So it's a big problem. Didn't used to be thought of as a problem, but now we know it absolutely is a big problem. We got to address it. Real quick, I'm going to run through what the same meta-analytic studies tend to say. You can look at that list, see if you feel the same way. You probably won't, because every given individual is unique. But overall, headache pain seems to be the most prevalent. Okay, followed by neuropathic extremity pain. Again, as a reminder, neuropathic refers to pain that's associated with damage to nerves, right? And that's obviously relevant for MS. And then back pain, spasms, and spasticity, followed by Lhermitte sign, which isn't really a sign, it's a symptom. And then finally, trigeminal neuralgia does not occur as frequently as the other types of pain. But when it does occur, and we've heard already through Q&A, it can be very significant. Okay, so let's not leave it off, depending on whether it's typical or atypical. Okay. Pain in MS, there is not tons and tons of research on pain in MS specifically. Believe it or not, there's really not. So if you're an aspiring researcher or academician or want to start doing some more research on your own, this is an area that's understudied. It's associated, pain in MS associated with higher levels of disability. It's also linked pretty significantly with depression and anxiety in the research, and that's important. We don't really know which way the relationship goes. That is to say, does pain cause more depression and anxiety in MS? Or are individuals with MS more prone to anxiety and depression, and that thereby exacerbates or makes worse their pain when they do experience it? We don't know, and it could be both, but there's a link. These links between fatigue, depression, anxiety, and pain in MS really underscore that biopsychosocial model I emphasized from the beginning, right? That this is not just a medical or biological concern. The psychological and social aspects of pain are significant. They're all interwoven. They really are. We are whole people, not individuals with just sensory pain-driven syndromes alone. Okay, so now we have almost half our time to focus in on the treatments. That's a good backdrop to kind of get your mind in the game. Let's talk about treatments. And again, guys, I listened to the neurologist and Megan talk earlier, and I heard a lot about just disease-modifying treatments, medical treatments, medicines. And I did hear a little bit interspersed about pain-specific medicines. Baclofen came up a couple times, right? So I'm going to leave that off. You know, because you only got me for a half hour and I'm a licensed clinical psychologist. I want to focus on the psycho, the pink or red circle there, and to some extent the yellow, the social aspects. Okay? I don't want to neglect those medicines, but again, let's learn something new about what else you can do aside from the medicines or in addition to the medicines. I have an analogy for you because I think analogies tend to work pretty well to help people understand more complex concepts, right? So let's pretend for a minute that the source of pain, knife in the arm, sorry to be so gruesome, right? In our analogy is going to be a foul-smelling landfill that's really close to your home. I drove past 3 of them here from Central Florida. Pretty bad. Okay, so then what is pain perception? What is the actual pain? Well, in this analogy, if the pain source is the landfill, then your pain perception is going to be smelling the landfill and that awful smell, right? That's pretty painful in and of itself, so it's a great analogy. All right, so traditional medical treatment approach to pain would be a painkiller. Opioid, analgesic, any kind of medicine that deals with pain. It's like putting a clothespin on your nose, isn't it? It's a great strategy. It doesn't necessarily address the pain source. Pain meds don't go where the knife is in your arm and change the fact that a blade went in your arm or a needle. No, but they help deal with the inflammation and they deal actually up in your brain in a very specific area and stimulate kind of euphoria. And so it's like putting a clothespin on your nose so you don't experience that needle in your arm. A nerve block is really similar. You may have heard of these. Someone mentioned, trigeminal neuralgia. And there's even occipital neuralgia you can have that you can get a nerve block for. It's like taking an extended walk away from the landfill, right? Again, the pain source is still there. The issue in your body, the biology is still there. But you're going to go on a long walk and get away from the landfill, maybe 3 weeks, a month, maybe 6 weeks, and you're not going to experience it. Then you got to go back in and consider another block, right? So finally, getting to the chase here for my piece is a pain perception modifier. That's my best terminology, to include all things non-medical. I threw in antidepressants here, but really what I mean is the effect antidepressants have on your mood, okay, not them as a drug, and behavioral and psychological treatments. This is like perfume, right? So we've got the landfill, or we love our home, we want to stay in our home, we're going to hang in it. We're going to live with MS and its pain at times. And so what we're going to do is we're going to find ourselves a nice little perfume, and we're going to spray the perfume somewhere near our upper area here so that occasionally as the wind blows in our life, we get wafts of our own perfume and it smells good. And now the landfill smell may creep in a little bit from time to time, get a strong downwind, and you're going to get a little bit. But again, remember the idea of the dials now and this analogy. The goal is to reduce that landfill smell as much as you can while still living your life and not having to run away from home to avoid it, or walk around with a nose clothespin on your nose, right? So perfume up there is good. It's going to help get that foul smell rating maybe from, like I said before, an 8 or 9 down to a 4 or 5. And wouldn't life be nice? Data related to the treatment of pain, specifically in MS, is limited. I said that already. I am going to skip for now, in my 10 minutes left, the discussion on cannabinoids. I know it was raised already. I concur with both neurologist and Megan Wagle on their opinions on this. We can circle back in Q&A if you want. Okay, but I'm going to skip cannabinoids and medical marijuana for the moment. Exercise or stretching is the first thing I want to talk about. And I know, and I don't see him still in the room, but you've gotten up, you've done some of that already. It's crucial, and the message has already been given to you. The biggest thing I see in medical chronic pain patients, regardless of whether they have MS or not, is their fear that when I move, when I exercise, when I walk, when I stretch, it's going to make my pain worse. And believe me, there are conditions that it will. It's called pain increasing on exertion. We hear it all the time. But what you can't forget is that your body needs to move. If you have spasticity, and it doesn't result in pain, let's say, but it results in just a gait issue, and maybe because of your gait issue, you have some opposite side hip pain or something like that. Not the biggest concern in the world for you, but you have this spasticity. If you just sit with that spasticity and don't address it and don't attempt to walk, or you have muscle spasms and you say, heck, I'm not going to walk. I'm not going to go there because there's a chance I can have one and it hurts and I might fall or something like that. Then over time, what's going to happen to your muscles? Number one, disuse atrophy. They will kind of dissolve away to some extent. And then guess what? When you get up to walk, finally you get the courage or something happens and you need to, they're not as strong and can't support you. You're making the situation worse, really, by not being active. The key about stretching and exercise is to do it in a very pacing manner. That, like both doctors talked about in the Q&A before me, everybody's an individual. Find out what works for you. If you can go 20 minutes doing this and you got to take a break because of fatigue or a spasm, take a break. But that doesn't mean stop doing those types of behaviors, right? Okay, the reason I put yoga and Tai Chi up, and I know you heard a little bit about this earlier, is because yoga and Tai Chi allow for both the exercise benefits of moving your muscles and getting those nerves working to stimulate your muscles, while at the same time they have heavy relaxation components, or they can. And that's important. So you're getting a double benefit for maybe your stress level or your mood issue with Tai Chi and yoga. There's good research to say it helps. Remember the dials. I'll keep showing these. We're looking at dialing it down, not making it go away necessarily. Relaxation training. This is great, and there is great research on all this. You can see I have some references in there, by the way. I'm just going to talk fluently about it, but know that it comes with research evidence. The big three here that I practice with my patients are diaphragmatic breathing, guided imagery, and something called PMR, or progressive muscle relaxation. That last reference on the PMR, 13 in the references at the end, is a study done specifically with MS patients. And it works. You got to be careful. Depending on how frequent you might get spasms, you have to consider that in doing PMR, and you have to do it with a guided professional to be most safe. But it works. Because of those earlier relationships I share with you about MS and depression and anxiety. We now know, I heard some talk earlier about stress. Whether or not stress induces an exacerbation is still questionable, as you heard the neurologist say. However, we do know that stress can exacerbate your experience of a relapse or of a particular MS symptom at any given time. Absolutely it does. There's no question about that. So indirectly, through relaxation techniques, you can bring your entire level of arousal down so that when you do experience pain, or when you do experience other outside stressors like caring for a loved one, I heard, you don't feel it through your MS as strongly as you might if you were in a constant state of being ramped up. I have just a few minutes left and a couple more things to talk about. Hopefully you're either taking notes or you've heard of these things, and I want you to bring them back to your providers. That's the goal. We're not going to be doing diaphragmatic breathing today. We don't have enough time. But if I can bullet point 3 or 4 more other strategies that have been proven to work, then take which ones sound nice to you that might work for you. Talk with me later or take them to your home providers and think about start doing that. Okay? So the thing about stress and anxiety and depression and any mood condition is where does the typical person, MS or not, hold their stress? Does anyone know? Yes, neck, shoulders. You guys are experts. This is great. Absolutely. Human beings tend to hold their stress in their neck and shoulders. And the broader point here is we tend to hold our stress in our bodies, physically. And because you're smart people and you've gotten to this place with your loved ones or your own conditions, you've learned that and there's no running from it anymore, right? When I do diaphragmatic breathing with people who haven't realized that yet, oftentimes I get floods and floods of tears. And we're not even talking about anything sad or anything really emotionally overwhelming. It's because they've held that tension in their bodies for so long without realizing it, walking around in the world, that when they're given the opportunity to let it out through a breathing exercise, they feel amazing. And I gotta wonder, and the literature says this is true, for folks with spasms or even extremity neuropathic pain, you are vulnerable too to having increases in pain in those areas that if you did the diaphragmatic breathing, you would experience your pain as lower than you would without that, okay? Let's see, biofeedback is what I want to get to, and I think that is next. Yes, biofeedback. This is a process by which we use electronic monitoring devices to capture your biological data. Things like heart rate, breathing rate, skin, all sorts of different things. Heart rate and breathing rate are the two easiest, and we'll go from there. And the idea is that by capturing your heart rate and your breathing rate, we can give you a picture of how messy those things can be when you're stressed or when you're dealing with something or you have a chronic condition, okay? And by giving you the picture, and I'm going to show you an example here in a minute. I'm going to skip past this. Okay, something like this. This is one of my favorite ones. I don't endorse any products up here during this talk, but take a look at what you might typically get. We've got here a breathing rate, I believe that might be heart rate variability on the left, and we've got an image. And what has happened is this person's biological data, how they're breathing and how their heart's going, is being translated into a visual image on the screen. The more relaxed the person becomes through the biofeedback exercise, the higher and faster their hot air balloon rides. And while they're watching their hot air balloon rise higher and faster, that feels good. It's like a video game. It's like a video game where you're getting reinforced. The nucleus accumbens in your brain is getting stimulated and saying, woohoo, euphoria, this feels good, let's keep playing. And through that process over and over again, you actually learn how to more easily and quickly get your body in that relaxed state through the biofeedback, okay? It looks like I'm just about over time. I'm going to dig into, I have 10-minute Q&A. I'm going to dig in just a second to introduce the last two. Mindfulness, I'll be real brief. Mindfulness is similar to biofeedback and relaxation in the sense that you can learn to become what is called a detached observer. And the briefest overview of what that means is to say you can learn to kind of step outside of yourself, it sounds wacky, and observe yourself in your experience of pain. And in doing that, you separate out that sensory and emotional aspect of pain that I came up with in the beginning and defined for you. And by doing that, you can reduce that sensory piece a little bit by observing it as an outside person. It's very meditative and hypnotic in a way. And the last one, and I see Stuart's here, so we got to wrap it up, but I'm going to introduce you to CBT for chronic pain in MS as well. And what this basically says is there are bidirectional relationships between everything up there. Our behaviors, our emotions, and in particular, it's important to consider our thoughts. Our negative beliefs about what our pain experience might be like. This might come up in a Q&A, so I'm going to leave this slide up here as we transition. But again, I went through a lot of data here for you and a lot of different behavioral and psychological interventions, at least 4 or 5 of them. The goal was to educate you a little bit, and if something seemed to stick in your mind, you can take it to your providers from here or follow up with me, and we can delve a little bit more deeply into it. So I hope this was helpful.
Thank you. All right, we're going to do Q&A for 15 minutes with Dr. Koenitzer. Maria's on that side of the room, and I'm going to be running around this side of the room because I have so much energy.
Also, please, feel free, since we skirted the top here, if you want to dig into one of these concepts I raised, I can go back in my slides and we can talk about that if that's where your question is.
Any questions over here? Great. Pick the furthest away. Couldn't get there a little bit at a time.
Hi, Doctor. I did want to quickly go into the diaphragmatic breathing.
Okay. So the question is, you wanted to just go into that more?
Yes.
Okay. Did you want to do it?
Quickly, yeah.
Okay. I don't know that we have tons of time to do it. I'll just demonstrate one very brief. If you want to do it along with me, it will not hurt you unless you have upper respiratory issues right now. I recommend don't do it. The basic thing with diaphragmatic breathing is to learn to breathe in through your nose. And as you do that, learn to fill up your diaphragm or your stomach area, let's say, as you breathe in. It's the opposite of what we're used to breathing. We're used to sucking our stomach in as we breathe in. So breathe in, fill your stomach like a balloon, nice and slow. And as you exhale through your mouth, slowly allow your stomach and diaphragm to deflate. So 2 key things. In through your nose, fill the diaphragm, actually push it out. I do it with my buddies and say, let's pretend like we're pregnant for a half hour. We'll do the pregnant thing. And then slowly exhale through your mouth and allow your diaphragm to collapse. So that's the one key thing. And the second is rhythmic, about 4-second paces. I'm giving you the cheat sheet here, guys. It gets much more technical. We can do it better if it's one-on-one and longer, but that's the idea. You want to do that. If you can do that consistently, sitting somewhere quietly, breathing in that way, very deep, in through the nose, out through the mouth, for let's say 10 minutes, the average person will realize the benefit at about 10 minutes. And then, of course, you might want to incorporate that into your daily routine and expand on the time. Okay, what else? Do we have another question?
Any questions on the...
Yes.
Hi, if I heard you correctly, you're associated with the Orlando VA, is that correct?
Yes.
Related to, pertaining to your biofeedback mechanism, I'm here in the Miami VA. The little bit I know about it from years ago is that you do something to look at your breathing, your body temperature, oxygen, some kind of sensors. When you do this biofeedback self-training, is there anything that you can give your patients through the VA for this?
So I don't want to speak on behalf of the VA, and in fact I can't today. I'm an independent practitioner also. I just am affiliated with that VA. I will tell you though, my knowledge is such that every institution is different, and there are certainly opportunities for biofeedback now, increasingly so, anywhere, to include VA. So I would recommend first checking with your home VA site. I got to imagine that here within the next 3 to 5 years, if there is not opportunities for biofeedback at your VA site, there probably will be. And certainly in the private sector now, there are many opportunities for biofeedback. I will say one more thing on your topic. It's very expensive, guys, upwards. I've seen them from $350 all the way up to $2,000. You can buy some of the software and some of the attachments and do this on your own. I highly recommend meeting at least once or twice with a professional who does it so that they can train you on the software and then let you go free.
One last thing.
Yes.
What I've learned to do to filter through the government sanctioned stuff is through the National Institute of Health.gov. But my question specifically, your personal opinion and experience, is it scientifically proven to have benefits? Is there a consensus on that, or is it?
Yes.
Or is it? Yeah.
Absolutely. And I try to be, that's a great question. I try to be very specific in my presentations here, not to bore you with the data, but there are no specific studies on biofeedback in MS pain at this point, but there are biofeedback studies, I skipped over the slide there, on CP patients, on almost anything under the sun that have shown that its efficacy, for sure. Excellent question.
Question over here, please.
Okay, rather than a question, you mentioned something about 4% of the people have trigeminal neuralgia. My husband was one of them. his experience was that when he went to the emergency room, none of the doctors knew what to do. They gave regular pain medication, which does absolutely nothing, whereas Neurontin or gabapentin and carbamazepine make the difference. But fortunately, our daughter went up on the computer and looked up trigeminal neuralgia to find that Johns Hopkins Hospital is the #1 in the country for treating this. And we were very successful with this. And we were with a doctor that does this all the time, and it makes a huge difference. But if you load up too much on carbamazepine, our neurologist said you increase your risk of falling when you do that. So you have to be very careful.
It's a heavy psychoactive drug, and any psychoactive drug is going to increase risks of cognitive issues as well as balance and falling issues. This, as you know, guys, this condition and any chronic condition is a dance, right? And I don't mean it in the sense that it's a balancing act. And I'm very happy for you that you found that outlet and that you can share it here for others who deal with trigeminal neuralgia. It's a very painful. Any other questions?
Question over here. Did you have a question?
Does this type of thing work for like the pins and needle feelings, the neuropathies?
Biofeedback, relaxation training, mindfulness absolutely can.
Thank you.
Mm-hmm. While she's walking, just a real quick follow-up. You ever see the guys who walk on hot coals? And you're like amazed by them, right? And they're not taking any anythings to do it. They're not high. They have used meditative states to train their bodies to deal with the same sensory stimuli, being those hot coals, that you or I would deal with, only they can do it. How do they do that? So that's what I mean about the extremity pain, the pins and needles. You can get into a state to where you have a different experience than you would otherwise, and a better experience.
Yes, could you explain the thoughts process up here on the slide, please?
I sure will, and I'm glad you asked because that's one of the slides that got neglected for time. So what this last slide on cognitive behavioral therapy talks about is the interrelationship between all these concepts. And in particular, I underline thoughts because they're crucial in this battle, right? So what happens with any chronic condition, and in MS is included, is we are all more vulnerable when negative stuff happens frequently to us. Exacerbations, spasms, pain, depression, anxiety, to starting to think more negatively. It makes sense. And unfortunately, the way our psyches work is that we have these thoughts that are called automatic. And the reason they're automatic is they happen all of a sudden out of the blue. You can't really control them. They're there with you. You're sitting in them and they say, this stinks. I don't want to go to the movies with my friend now and experience this spastic muscle the whole movie long. I'm going to be interfering with people around me. I will not have a good experience, and I'm probably never going to have another good experience at a movie again. So I'm done. That would be catastrophizing, by the way. The big snowball of negative thinking that rolls and rolls and rolls and collects everything in its way. And so through CBT for pain, you learn to identify the specific vulnerable thoughts you might have as an individual that come up. You learn to catch them. We call them catching ants. It's a good analogy. You catch the ants as they run through, and you examine them and say, wait a minute. Is this really true? Am I going to have a miserable life and never be able to go to a movie again? Okay? And through the process of challenging the negative thoughts and reframing them into something a little bit more realistic, usually positive, but realistic, over time can begin to push off the automaticity and the frequency of those negative thoughts. And the effect is, from this graphic, that's going to have a positive effect on your mood, which is then going to have a positive effect on your experience of pain and your behaviors and your willingness to be more social. And it's a very, very nice web, what I call the reverse spiral. Instead of going down into that black hole, you start to come out into life again through addressing those thoughts.
Question over here? Or were you still answering that?
I think I'm done. Was that sufficient
Sounded
answer?
like that. It sounded like it was the end. Next.
I I have very severe low back pain. It started out sacroiliac pain years ago. Now just even sitting here, it's just very, very painful all the way across my low back. I mean, actually, it's more in like this low back, sacroiliac area, or just where I sit, and I don't know what to do about it. Just sitting here is very painful.
Mm-hmm. Yeah, and we always say up here on the stage, we can't be your doctors in the moment. I don't have that relationship with you, but you could stand up if you're able and stretch. I certainly don't mind in these things when people are moving about. Happens all the time in my office. Hey, doc, I'd love to finish this conversation, but I got to walk to your corner and back. So that can relieve some of that at times if you pace yourself. The other thing is, like Dr. Nagrosky said, I believe, everybody's unique, and all of these types of interventions work really well together. I love working with the neurologist because we talk, are they at their optimal level of baclofen, for example, or carbamazepine, someone brought it up. Now, if they're there and we don't want to go there anymore, we don't want to risk some of the negative aspects of pain, let's get them involved in a pain treatment team that involves a pain psychologist to supplement. So it sounds like something you can consider if you haven't already is getting a little bit deeper into team-based care to have different providers bring alternative approaches to your back pain to the table so that you can find which sampling of several are going to give you your overall relief.
Are there any more questions on pain? Anybody have a question? Well, that being said, wait, there's a question. Wait, let me run.
I can't run. Hi, I have trigeminal neuralgia, and I'm on huge doses of carbamazepine, and yet pain still breaks through, and I end up in the emergency room. They give me first a IV with a muscle relaxer, a painkiller, and I forgot what the third one is. I've already had the one where they put the needles through to go to the back of the brain, and they just up in the carbamazepine, and it's really a pain. Any other suggestions?
Yeah, and the gentleman over there asked about the research evidence and does this stuff work. I have not seen literature specifically on non-pharmacological or behavioral psychological aspects of trigeminal neuralgia, but all of these approaches could work, and from what I can tell, the risk of harm in trying them to see if they work is extremely low. In fact, one of the big risks that we talk about when risk is so low, obviously, is just the risk that you would get up too much hope. That's part of the risk profile, and we don't want that because we don't want to send you down further if it doesn't help. Okay, but once that's considered, I would absolutely at least attempt something like mindfulness or relaxation training.
No more questions? With that, we all have to thank Dr. Koenitzer for coming here today. Awesome. Thank you much. Thank you much. I have a certificate for you.
Well, can I take a quick opportunity? Stuart told me not to do this, and I heard him earlier say, oh, it's not about me, it's not Stu's news. But one more, I can't leave here without you all giving this guy one more round of applause. He does amazing things, really. Real quick, I've been doing some of these talks with Stuart over the years, and every time I see him, it might be a couple months that go by or more, I come to one of his events and it's expanded, and that's amazing. It's expanded and growing, and he's getting the word out, and he'll continue to do it with your help. So thank you, Stuart.
Thank you for embarrassing me. How often do I get embarrassed? So here's a certificate of appreciation for you, Dr. Koenitzer, and we appreciate you coming down here, making the drive. And Dr. Koenitzer was supposed to do this for us many months ago, but that's when we had Irma? Yeah. And he couldn't make it down because he had too much water in his home. But again, thank you for coming down here today. We greatly appreciate it. We'll speak to you later. Thanks again. So, our next speaker will dazzle some of you. She might give you goosebumps. She might make you feel special or indifferent. I really don't know what she's going to do for you, but her name is Marilyn Volker. She's a doctor of education and has practiced as a sexologist and gender specialist for 40 years. She is board certified with the American Board of Sexology and the American Academy of Clinical Sexologists. She's actively working with soldiers and their partners who are returning from deployment, helping them to reboot their intimacy. Dr. Volker is an adjunct professor at the University of Miami, FIU, Barry University, and St. Thomas University. Let's welcome Dr. Volker. You want to take the steps? You got to come up here.
I got to come up here?
Oh my God, yes, you have to come up here. You want to hold this, or do you want to talk into that?
Oh, well, I'll see. Pretty phallic looking for me. Okay, all right, no. I want to just say, first of all, I want to say thank you. We give safe claps in my business, so that's great for you. This is like sex. You got to know the position and the holding and the... I know. All right. That's the interesting part. First of all, I want to congratulate you and Stuart and Jennifer and all the people behind the scenes. You've been here since 9 o'clock, right? How many of you are tired? Come on. It's okay. It's okay to... Yes, thank you. One person. How many of you want to go see that U game? Come on. That's it. I know. So we're going to have a quickie. We got 15 kids coming over to our house to look at this. So I'm really glad to see you. Now, usually there's a clicker. Oh, yeah, here it is. Okay. That's good. All right. So the interesting part about what I have done, I want you to know that yesterday was my 71st birthday. And I know. Is that amazing? No, that's amazing. And I did not aspire to be a sexologist. This is sign for grow. This is sign for ejaculate. Okay. The reason I'm saying that you're all going to remember and wakes people up, okay? The reason I'm saying this to you is that when I was growing up, I never aspired to be a sexologist. I wanted to teach deaf kids when I was 13 years old. I was an arrow, and some of you are arrows, and some of you are wanderers. And between our 4 children and 10 grandchildren and 40 some years together with my husband, is that the interesting part is that I just wanted to do that. I saw Helen Keller, I wanted to be Annie Sullivan, that was it. And then something happens. It's called a marker event or a marker experience. And then your lives are never the same. And mine was a little deaf boy named Brian. If you heard the story, I'm going to make it short. But I have to give honor as to why I'm standing up here with this topic. You see, I had my class, my undergraduate, my graduate, deaf education, special ed. I thought that was it. And then you get humbled by a child or life and circumstance. I told them that all words meant something. Bring me words. Now, this is pre-Google. Who's standing here pre-Google like I am? Who's standing here? No cell phones, no go. Okay, all right, I get it. Okay, so the interesting thing is that they brought me words. And then there's this word called irascible. Now, an irascible kid, and some of you are like that, an irascible kid or adult is the one who doesn't give up, angry, look you in the face, not going to take your word for it. And his name was Brian, 9-year-old deaf kid who brings me 3 words, and I can see it 40-some years ago. He's running in and going, what? I look at these words, and all 3 from bathroom walls. This is the true story. I'm a minister's kid. I never took anything in sexuality. We never talked about anything neck down, thighs up, front or back in my house growing up. But my daddy said there's nothing nasty about your body, and my mama. And I'm grateful. They'd say you'd be defaming your creator. My military Marine uncle said, Missy, you better know about your body so you don't get tricked out there. So I kind of got a good balance. And my parents said something also. They said we are to value all people, not just white, not just heterosexual, not just cisgender, opposite of transgender, although these words weren't even there, and not just young, not just temporarily able-bodied, everyone. And so I took that purity. So it was really, really easy, but this was not so easy. I looked at those 3 words. I couldn't even sign them, well, half of one, mother. Okay, I now know how to sign it all. And the really interesting, I told them those words were nothing. Just like sometimes when people live through and with diseases, people don't talk about things that are very, very important, like your sexuality. Whether you're having sex or not is not the issue. The interesting part, and you're going to see there's 8 types of intimacy, only one is sex. The interesting part about this is I wasn't prepared. I hadn't taken one sex class, not in high school, not in undergraduate, not in master's, nothing. And so I told him those words were nothing. Do you think he believed me? Do you think it stopped his interest? But what he did was the takeaway. He was here, I was here. He was so mad he signs, "Liar you." I had lied. He says, "You say all words mean something. Now what?" I said, "Nothing, nothing." The takeaway was he never brought me another word again. What had I done? Come on, not perfect, just accountable. Old AA, what is it? I broke his trust. And what happened was, I went home, I thought, there has to be a way to teach. I'm a teacher, you're a teacher, you're a teacher. There has to be a way. And so that's truly how the minister's kid, former minister's wife, because in my day, if you had a vagina, you married a minister. If you had a penis, you became a minister. Okay, that was how it was. My former husband passed away. And the interesting part is that that's truly how, and I have to give honor to this little 9-year-old deaf boy named Brian who took me to the mat. And so I really continued with a lot of interesting things from the womb to the tomb, all kinds of changes in bodies. And so when I sit very humbly with this, and I look, this is my heart on, this is an adult show, okay, I'm not going to show you any naked pictures, if you want to be naked, okay, but this is the interesting, I call this the hearts on before hard-ons slide. And so all of you, no matter what you do in your intimacy, you're bringing your hearts on. You're bringing the heart part. And when I work with people, I truly see their heart of all kinds. And so and I listen to the real experts. That's you. No offense, you've had wonderful presenters, wonderful. And I work with the medical, we do sexual health and medicine in a lot of medical schools over the years. But the real experts are you. And here's Carolyn who said, MS means multiple sclerosis, many scars, many symptoms, many struggles. Oh, I have to look here. Okay, modified sexuality, more spirituality, mighty strong, much support, many successes. My story, and each one of you has your story. Oh, by the way, my daddy said, if you're religious, you'd be thanking your creator for your sex response. If we get time, we'll see that, because our people up there are going to look at that one called Honoring Your Sexuality. Very short, it's quickie. Okay, so wherever you are, this is one part of really affirming your sexuality. Touch. Now, some people with MS, it's like, ouch, or some types of touch. Better or not? I worked with a couple who, she said, almost you have to put something in between your skin and me, something soft. And all right, who made the rules? Who makes the rules except you? Now, how many of you are single? It's hard for me to see. How many of you are single? Raise your hand if you're single. What do you like about being single? What do you like about it? Come on. Freedom. You get to do what you want to do, when you want to do, how you want to do it. How many of you are coupled and married? Let me just see. Coupled and married. Does that mean you get to do what you want to do, when you want to do? No. My husband, who's 60, I'm trying to think, 60. I tell people I'm 75, so I don't even have to think about it anymore. Maybe when I get to 75, okay. All right, so the interesting part is he's 67, and no, 76. Got it backwards. 76. He's lived through 5 heart attacks, 5 stents. He has high blood pressure. He has diabetes. Are you thinking diabetes? Are you getting blood flow? Are you getting this? Boy, did I learn from the real experts. Blood flow means you got numbness, you got neuropathy, and you don't always get blood flow to your genitals. So who said sex is all about genitals? I learned from the real experts. People who said when plan A doesn't work, go for it. Plan B. What have you got more of, public parts or private parts? See? But no baby comes out of the uterus thinking, oh, it's all about here. No, it's really all about here and here. And so with great honor and with a bow here. And so when I talk, because I have such a short time, oh man, if you want to be a sexologist, and many of you, come on, take some training. We have it now in South Florida. Some people get shocked. I don't mean to shock people. I don't. I just know that sometimes people don't offer this. They don't talk about it, okay, as just part of who you are. And some people go, I'm okay, but inside, who is that weird woman? Sign language for weird, okay? On the second to the right, you might get mad. When people get mad, here it is. When you get angry, it means there's something behind it. I expected something that didn't happen. And you can get upset, and you can get hurt, and you can get so frustrated. This is sign language. I'm sure many of you wake up and you're dealing with things and watch this sign. Frustrate, walking in a wall. And I'm so impressed because it means I can say, I'm frustrated. And now let me see what I can do and can't. Okay, the person on the left and middle is going like, ugh, I don't want to do sex anymore. Well, you don't have to. There's 8 types of intimacy. But if you're with a partner, who said you always have to feel sexual? Who made that rule? All right. I learned you didn't have to feel sexual. When I went to the seminary with my former husband, it was in St. Louis. So who's in St. Louis? Masters and Johnsons. They come to present. We're like deer in the headlight because we're like 19, 20 years old. Who gets married at 19? But okay, we did in those days. So the interesting thing is that their research said you're supposed to be really excited. What I found is, no, you can be neutral. You can be and willing to see what's possible. And you can stop at any time, unlike porn. I'm not for it or against it. I call it adult films. And is there MS porn? I'm just curious. Who's researched that? Who would be willing to say that right here? I know. Okay, so the interesting part is, on adult films, which I'm not for or against, it is very, very scripted fantasy. Everybody's excited. Everybody loves every position. Nobody has pain. Nobody has MS fatigue. Nobody takes any medications where they're like, that's it, that's too hard. No. Everybody has orgasms and ejaculations simultaneously and continuously. That is fantasy. Sign language. Fantasy. Great fantasy, but not reality. So, the question should be not, do you want to have sex? Because sometimes the answer is, come on. But if you say, could we do something close? Or can we show affection in some way? In my office in Coral Gables, and I've been blessed to have 2 offices in Hollywood, I have watched people to find the puzzle pieces for them. Not like anybody else, but they create the rules about it. What are we going to do to be close? The person on the bottom laughs. Well, some people laugh. It's a feeling. And I'm going to just say something because we're seeing it in the media a lot right now. Sometimes when I talk, it triggers people. I was one of those Me Too's. I was one of those who got raped at 17 on a college campus. Of course, we never talked about it because it was never talked to us. So I never talked about it. Much later, I realized, what that was. Oh, that blood wasn't your period. There's a lot of things. If you don't have a place to talk, I encourage you to talk. And find safe people. So, fear, belief, and comfort. That was Joanne, who lives with MS, who said, I was fearful to talk about this. I didn't want to be made fun of or thought as weird. My belief system is I had to be perfect all the time. And if you grew up in my day, you had to be good, perfect, nice, pretty codependent, okay? And comfort. Well, unless you're 50 shades of some, and some of you might be, because I work with people with paraphilias, but most of us want to be comfortable. Most of us, in our experiences. And so here's Joanne. And Joanne had a lot of interesting things about sexuality. Are there changes? Well, there's changes for everybody in our decades. But what are particularly about MS? What about the 3 Ps? Physical, the disease, psychologic, how you feel. Always remember 3 Ps. Physical, psychologic, pharmaceutic. What am I taking? You know what I'm talking about. It says on TV, take this and you feel better. And then on the bottom, what do they got? Come on. What do they got? Yeah, I call them cover your ass. The cover your ass side effects they have to do. Yes. And so there's this constant, and I know this because my husband, God bless him, he has more doctor dates than anybody I know. And he always has to talk about what's happening with his medications. So the interesting part is, Joanne was talking about frequency, fatigue, discomfort, need for more or less stimulation in different ways. Oh, how about bladder? Let me just say something about sexuality and bladder. You remember? Does anybody remember that G-spot thing? Remember that G-spot? Anybody remember this? Okay. Let me just tell you. Anatomically, everything is. This is where the G-spot is, named after a doctor. G. Grafenberg. It's all medical. And depending on physical, come on, give me the rest. Psychologic, what's an S? Pharmaceutic. That's it. But the G-spot is 1 or 2 fingers toward the tummy. Man, if there was a male and female, that man have to have a penis that looked like a crane if he was on top. I mean, just think about it. I'm a very logical person. Okay, so the interesting thing is, but toward the tummy, anatomically, if you know your anatomy, that's a woman's bladder. So unless you want to urinate, which by the way, urine has less bacteria than spit. I was always this irascible kid. So then why are we making spit so great and urine so bad? I mean, I'm just curious. Ask a doctor or nurse. Okay, unless you have a bladder infection. Okay, please don't go out of that room and go, oh, geez, that Volker, man, she and her husband must do weird things. But the interesting thing is, there are a lot of people who pee. And they pee laughing, they pee coughing, they pee in sex. That's what towels are for. There's all kinds of things. Genital sensations, which might change. Some people say, and I remember talking to a guy and he said, I don't feel really anything from the waist down. So all right. He said, I like to see my partner or partners, he was single, I like to see them. Because where's your biggest sex organ? Here or here? Always in your brain. Always. In fact, your genitals wouldn't work unless your brain would work. So the interesting thing about it was, he said, I really get more sensation waist up. And so he and his partner did a lot of things waist up, which they never show you, or they think is weird. So I don't want you ever to deny what's happening with your body. And by the way, if you're older, this is just an interesting thing. I was on a piece of research. I wasn't doing the sex, but we were, because people always think, oh gosh, what do sexologists do? Okay, so the interesting thing is we were collecting things about men getting older, and of course the changes that happen. And a lot of guys ejaculate better. Sometimes as you get older, you don't ejaculate. And sometimes if you got prostate issues, that's an issue too. And some guys with MS, depending on what's happening. But sometimes they can stand up and ejaculate better. Now, who tells you that? Who says, it's probably, you might want to stand up and see. Who says this? That's my job. And I think, wow, why can't we talk about these? Just like we talk about all the plan Bs that MS might require us to do on some days. I know. I also want to give honor to my friend Amy, who passed away numbers of years ago, and she used to do these workshops with me, and Jackson had MS. Oh, did she have stories? Single woman who loved to date. Okay, less responsive, less initiating. Concerns about partners' feelings. And in this word normal, whatever is normal for you right now, you want to be able, I can do this best. This is how I respond. This is how I feel. How about you? Okay, so the questions are, this was put together by some of the women with MS. Is sex going to be different now? Well, yes, it is different and some will be the same. And, let's see, will I be able to have orgasms? All right, let's talk about orgasms. Who of you growing up heard the word orgasm? Not me. No. This is sign language for orgasm. This is sign language for afraid. Be careful where you put your hands, right? Oh, have I made mistakes? Whoa. Okay, like learning any language. All right, this is sign language for lunch, which you just had. This is sign language for lesbian. Don't get those confused either. Lunch, lesbian. Of course, we got more than 10 people, so there are gay and lesbian people in the crowd, of course. Okay, but will I be able to? For some people, orgasms mean achievement. For other people, it means pain. Oh, you know pain. This is headache, heartache, pain in the ass. You know that. So sign language is wonderful, but orgasms is, and this is it. It is a muscle, it's a very, very medical. It's a muscle contraction in your private parts, created by your God-given, if you're religious, you're scientific, like my Marine uncle. It's your autonomic nervous system. Responsible, think of muscle. Burping, coughing, sneezing, passing gas, whoops, it's all the autonomic nervous system. But we don't get to talk about it in what I call honoring. So some people have more orgasms and some people go, TBC, to be continued, or thanks, I'm done. Do you have to say something? And that's the important part of communication. Will my husband, partner, significant other, will my partner of same sex, opposite sex, will they be able to understand? I don't know that anybody will be able to understand what it's like to go through MS if they've never gone through it. And I don't think everybody has exactly the same experience. And that's why we need to communicate. And partners do too. May I just say, I get more concerned when my husband goes to the hospital. Partners may get more concerned when you have one of those flare-ups. What's going to happen? Okay. And so they need support as well. Is sex going to be painful? Well, how many of you live with pain? Raise your hands. Come on. I'm assuming it's most everybody in this room. Thank you. So that it's good to say, when is it not going to be painful? When do we stop? When is my medications going to help? And so everybody has to communicate about that. When can we start? This, my dear friends, is the holy grail of intimacy right here. And I have to give honor, really have to give honor, because this is not something I made up. It was something that 9 women and I who were in recovery, so take your pictures of it, or if you want it, you can take my card, I'll send it to you. I'll send you this whole thing. It's not anything that I have copyrighted, because it's been put together by you all, the real experts. And these were 9 women in recovery, and they were all raped or incested growing up. And so for them, intimacy meant sex. And they didn't have any of this. So I want you to please evaluate your life right now. How many of you like affection? Raise your hand. Yep. Hugs, kiss, tweets, texts, maybe or maybe not from our president tweets, but okay. So the interesting part is affection. Could be that, or it could snuggling, holding, or one woman said, it's too painful sometimes, so we have to do this 3-second rule. 1, 2, 3, okay. Or we hug arms, or I hug her hair. Okay, all right? The interesting thing is affection can be, random acts of kindness. You know what I'm talking about. This is my army husband, who learned to make beds, cook, change diapers. Oh man, he should be cloned. Amazing, amazing guy. Still working full-time, 76. And see, interesting thing is, but he's in and out of hospitals and in and out of doctors. Interesting thing is, I'm going to tell you what he did this morning, which I think is the best affection. I was sleeping. He went out because he does shopping. He loves to shop, BOGOs. Okay, all right, so he goes out and he fills my tank, and I'm talking about my car now. He fills my tank with gas. He doesn't tell me. And I go out to my office and I think, I got to get to that gas station. And I turn it on, and when I see that gas gauge, I think that is one of the most marvelous acts of affection. Now, what do you think he might be needing? Come on, what was he wanting? Look at these other 7. See, he might be wanting something sexual. I think there's like a thing that see there, okay. So he might be wanting something sexual, and that's great, because that means his brain is working and his testosterone is still intact. Yeah, and that's what creates your hypothalamus and your testosterone. And by the way, women have it. We don't have it as much because we'd have hair on our chest and face if we had that, and lower voices, okay? So some of you might want social. That's I call the vertical before the horizontal. And I don't care if you're in a chair or whatever you're in, you want to connect. And so some people need that. Some people need emotional intimacy. I call this lubrication of the spirit before the vagina for women, okay? I call that. Men need that too a lot of times, I found. Intellectual, you know what I'm talking about here. She was in one of the MS groups that I had come to and said, got to get me here before here. Got to get me here before here. I call that intellectual orgasms. Great. You don't have to be a big intellect. If you're talking about the you game tonight, that is it for a lot of people. All right. Spiritual can mean either same religion or same values. Save whales. All right? Get involved. All right? Physical can mean doing things. Dancing, stopping, playing video games, whatever, gardening, cooking, whatever it is. And, walking your furry babies or playing with furry babies. Okay, aesthetic does not mean your butt. The teenagers go, it's that butt thing, Dr. V. Now, aesthetic means sharing something beautiful. And what you share with people. Now, do you have to be having sex to have intimacy? Answer? No. Do you have to be in a relationship to have intimacy? Not a sexual one, but we're all in some kind of relationship. That's correct. And now we get to sex. Outer course means, here we go. Outer course means skin, not in. On me, not in me. You got it. I was working with a couple and they said, we really like a lot of skin. And then we get tired, so we don't do in. Who cares if they're both happy? Very clearly. It was so interesting. Or we pick it up the next day. That's a very creative and complimentary. I'm going to ask the AV people, IT people, do you have my honoring sex response in? I always like to throw this at people at the last minute. Do you have that honoring sex response? When you do it, just put it up. I'm very flexible, plan B. So now I want you to look at this, and I want you to see you. I want you to see where you are. Do you think you could get all 8 from one person? I'm just curious. All those 8. How many of you think, I could get all 8 from one person? It's all right. It's your opinion. This is no. Okay? How many of you think, I don't think so. I got to go with my, buddies that play cards or mahjong or something. I don't know. All right? Some people say, I want to be working on it and see what's possible. And see what's at. So the interesting part about this is how many of you have learned that, look at them. Can we give a real hand for the IT? You're looking at the techno-dino me. Thank you. I want to say this. And how many of you learned some of the secrets of a relationship is what my husband and I called deals. I know they say compromise, share. We call it deals. In business, do you get everything you want? Answer. Do you know what you deal and what you won't? And do you have to compromise? Yes. We call them deals. And here's my husband. Here he is. Happy wife, happy life. Wow. Amazing. Okay. All right. I make him happy too. Okay. Here we go. All right. So here we are. It all starts in your brain. This is your sex response. We're going to go very quickly. This is all the medical part. You got a problem in your brain. You got any disease that goes to your brain, any medication that affects the brain, it's your hypothalamus. And guess who had, that's your sex center. Okay, guess who has a larger hypothalamus? Boy babies, girl babies, or intersexual babies? I started out at the Mailman Center for Child Development, University of Miami Medical School, and we saw children with all kinds of interesting combinations, chromosomes, hormones, and I called it shooting craps in the uterus. You got what you got. Extra chromosome, Down syndrome. All right? So the interesting part is now we're seeing some people who have girl parts can get boy brains, but who do you think got a larger sex center, hypothalamus, generally? Girl brain, boy brain, intersexual brain. Just vote. How many of you think girl brain? How many of you think boy brain? How many of you think in the middle? Intersexual. How many of you think I want to go home now and I'm done with this? It's all right. It's okay. Or go to the bar or something. I don't know. All right. So the interesting thing is, here's the answer. Boy brain. Is this giving you a clue? Mostly boys want, as they grow up, they're more interested in sex. Number 2, pituitary gland. The hypothalamus tells the pituitary gland, so if anybody's got a pituitary difference, go send down sex hormones. Remember I said testosterone? Who usually has more testosterone? Usually. Males. That means they're going to want sex more. They're not pigs and dogs, but that doesn't mean you have to force people. That's why my daddy said, God gave you 2 hands. And my uncle, the Marine, he said it like it was. I was 13. He said, Missy, better to be a masturbator than a perpetrator. And I'm going, what is that? So I was one of those people who looked it up. We didn't have Google then. What did we have then? Born in 1946. Dictionary. Remember that? Okay. And I'm like, oh, well, that makes sense, but oh my God. Okay. So here's men's testosterone usually, except it could be affected by the 3 Ps. Give them to me. Physical, psychologic, pharmaceutic. Right. Men's more like this. Beep. All right. All right. Here's women's testosterone. Here we go. Okay. Okay. Now, when you're in this, I remember somebody once came to my office and said, why can't my girlfriend always be, and I went, probably would have to be a male. Okay, so the interesting thing is that a lot of people have, yes, at 71, I don't have the hormones. I don't have the hormones like I had. Some people take hormones, some people can't. Some people don't want to. All right? So the interesting thing is hormones. If you got a pituitary problem, if hormones change, okay, now your spine has to be in place. I work with soldiers. If your spine has to be in place, it's going to carry the neurologic messages. Neurology. Haven't you had presentations by neurologists today? A sexologist always think about, how does that affect? Oh, so if somebody had something with a high, like I've worked with soldiers, high, incomplete break. Oh, like that Superman guy. Anybody remember that original Superman? What was his name? Reed. He had a high incomplete. That meant he could get an erection but not feel it. Do you think he liked seeing it? Yes. Do you think he liked having sex? Yes. Because the biggest sex organ is here. Was he frustrated that he couldn't, but he probably didn't ejaculate? Right. So you want to just look at the things about the spine. If you get tired, if you're in pain, if neurologically these messages aren't going to get down, okay. Who said you even had to get aroused or get an erection? Who made those rules? I've seen people have orgasms. Armpits, nipples, out the head. Stick with us. Learn a lot. You be you. Don't think you have to be like somebody else or even what you were before, which you have to grieve sometime, I understand, and then see what's possible. The spine. Okay, the next step, these are all physical. The neurotransmitters have to carry messengers, and that's neurologically too. They have to send blood down. They have to interpret whether this feels good or not. Am I in pain or not? Okay. Right? Chemical messengers. And drugs and alcohol can affect it. And I know some people struggle with alcohol, or people struggle. We have a son who allows me to say he was in the Navy, 7 years in recovery. And any of you who are into and also take meds with the help, that's amazing. I think that's amazing of anybody. So the interesting chemical messengers have to be in place. Oh, I love this one. Now these two are not medical, because those were all the brain and then the neurology. Here is the psychology. Ready? Number 4. You start out thinking, this is it. This is a good day. I'm having a good day. Less pain, less pain. I can do this. This is good. Okay. And then something happens. Now, if you have an expectation that it has to go in a certain way. And there's a lot of people who say, you know, Marilyn, when I get in pain, we go, oop, TBC, to be continued. Or, oh, let's see if I can either have a difference, or this is for you. You know what? I'm fine. I'm fine. So the interesting part is, I'm going to tell you my favorite story of 2 adults. One had MS, one had debilitating arthritis. 93 and 92 respectively. I want to be like them. They're now dancing with angels. And I asked them about their sex life, and they were saying, you know, Marilyn, we have sex, but not like we used to. Not like when we were 20. But we love to hug and kiss and do touching of all body parts, and sometimes we continue, and sometimes we fall asleep, and sometimes not. But on the days we have sex, she says, we don't wear underwear because we got a little arthritis going. Don't you just love that? Plan B, plan B. I love that. Now here's your limbic system. Here. Your limbic system means How many of you think I'd like a clean body if I'm going to hug, kiss, hold, or go on to some kind of genital sex? How many of you want a clean body? Okay, clean fetish. Okay, all right, so that's called a paraphilia. Okay, so the interesting thing is I've gone around the world. I belong to an international sexology group, and I've gone around the world. People don't think about Puerto Rico. They haven't had water. There's a lot of people who don't have that privilege of cleanliness. Some of us do. And some people like sweat. Some of you I know like sweat, smut. Oh, yeah. Well, one gets one on the way to the shower, one gets it on the way back. And who said you have to be in bed? There are people who said, I'm in a chair, Marilyn, and they said they learned. And by the way, if you're anybody here who's got in a wheelchair or something, I want you to look at my friend Mitch Tepper, because he made one interviewing soldiers, and it's called Making Love After Making War. Killer. Great, amazing talking to soldiers and their partners about adapting. Very great. So some things are negative. I can't do this. I don't want to do this. This is too painful now. I can't. And questions. So if you have questions, look it up. I'm going to leave today for your library that it's so amazing that I want very much to leave you with your library. I'm going to give that. And so you have a lot of information about sexuality and MS. This is all brought to you by your autonomic nervous system. So Stuart, you'll have paper that you can just put out to the world. Autonomic nervous system. It's responsible for erections, lubrication, ejaculation, or orgasm. And did you know that men do not have to get an erection to ejaculate? Uh-huh. Yeah. See, it's two things, okay? And all you guys know this. When you were little boys, right, you became friends with your penis, right? You had to hold your penis, right? All right. And then you knew which side of the pants that it laid on. So you became penis friendly. Okay. So the interesting thing is, then in puberty is when you ejaculate and learn, but the holy grail of ejaculation is your prostate. Mm-hmm. Once the ejaculate gets to your prostate, you will ejaculate. It's not a piggish, it's not doggish, it has nothing to do with love. No. Gotta just learn to control. And sometimes medications affect it, or prostate issues, along with MS, along with that. So I was just with a group of 12-year-olds, boys. Grandma, abuela, I know, yeah. We're talking about your body. And I showed them the outside, the inside, it's in their puberty classes. I said, this is your prostate. Oh, that's for old guys. No, you have them. And you know when you're touching your penis and you're masturbating in private, all right, is that you slow down. Why? Because someday somebody is going to be so grateful. Kind of like getting that. So your prostate is the holy grail of ejaculation. It's different than women, because women's brains with a smaller hypothalamus, wavering testosterone. Here's the third little wicked witch at the christening. There's a part of the brain, I forgot to say this, that puts the two halves together. It's called the corpus callosum. The teenagers we teach call it the CC. And so in a female brain, no matter what's between the legs, it's thicker. That does not mean smarter. A male brain, no matter what's between the legs, is thinner. Thinner means you can focus without interruptions. I'm going to ask every male in this room, when you ejaculated, did you ever worry about how fat you were, how cold it was, whether somebody was going to interrupt you, or what you said to my mother 5 years ago? With all due respect, if you had a thicker corpus callosum, it is why women could be right at the point of orgasm, and then something, and that's it. We got to be respectful of this. Yeah, exactly. I know. Oh my gosh. I was grateful to learn about that. Okay, me personally, I'd rather have a man's brain in sex and a woman's brain outside. And my fifth graders, once they learn about the brain in sex, said, we're going to be able to have robotic changes so you can do that. And I'm going like, oh boy, I don't know about that, but we'll see. Okay. So if everything works, it's A-okay. And this was put together by our peer teenage group, A-OK, some of which live with diseases, and they always say, just say no. Can we put back the other MS? And we're going to go really fast through because I'm looking at my time. Can we put back the other MS and sexuality? We're going to use your head, the one between your ears. All right. Use your heart, not the one between your ears, between your legs. Use your heart. I'll do this, but not this. I can't do this today. I can do this, and always be safe in 3 ways: physically, emotionally, and sexually, which is why I do bring things. When I'm so far away from you, I feel really, I brought things. What does a sexologist give out? Water-based lubes and condoms, so please. And my icon is stars, that's what it is, so please take some stars and give them. So we're gonna get back to that. And water-based lube, because many, many, many times it is important to have more lubrication. Please. No Vaseline inside the body. No oil inside. Okay. Water-based. So you'll come up and get some, or I'll start to throw out. So here we are at these 8 types of intimacy. Okay. That's why they put me at the end of the day. Infotainment. I get it. So I hope you take some takeaways, but in an interesting way. You should have seen my daddy work a church crowd. Whoo-hoo on there. Okay. All right. So the interesting part of this, oh yeah, here it is. See, now that you know those differences, maybe Miss Pooch, who lives with MS, she doesn't really have a headache. She could. But what could be happening? She's in pain. She's too tired. But she's like really kept it all inside and didn't talk to anybody, so it comes out. And, well, maybe if well, first of all, how does she look? How does Miss Pooch look? She's angry. Behind it is something much more vulnerable. Oh, come on, a little compassion for Mr. Pooch, too. How does he look? Scared. Intimidated. I find most women, the difference is they're like gardens. You work on the outside and you come toward inside unless they're ready, all right? And you got to know the 4 T's. Got to know the 4 T's. I like numbers. Here we go. Would you ever start a car in 5th gear? What would happen? Stall. She got to know the 4. Oh, she could just lay there. But here it is. Talk, touch, time, trust. That could be for men too. But men with a larger, more testosterone, if everything's working on a good day, thinner corpus callosum, you could start right in the genitals. That's cool. That's why my father and I, when he learned about this, we decided God must be male because he made men so efficient for sex. But here we go. Okay, that was just a father-daughter thing. Okay, so the end, conversation. So the interesting thing was, look at Mr. Pooch. Maybe if he offered her a doggy paw job, manual sex, she would be fine because an orgasm releases morphine-like pheromones. We have a lot of chemicals in our body that can get interrupted by anything physical or disease, MS, anything psychologic. I'm not the same as I was. I hurt. Who would want me? And it's changing. And also our meds. Why is my desire for sex decreased? Well, that's hormones and meds and any disease you can see. Physical, psychological, pharmaceutical. Energy levels can be decreased for both males and females. And here we're from the real experts, really fast. Will my partner find me attractive? Can I be a good lover? These were all the questions from people with MS. Why does it take me so long to get turned on? Which is why you could enter a neutral. Hey, babe, you want to get it on? I don't feel it. Well, let's just start and see what happens, and you can stop at any time. Kind of like food. Let me just ask you, do you ever tell your partner, are you as hungry as I am? Oh, no, we can't go to the restaurant. You're not as hungry as I am. Oh, how about movies? Do you really want to go? This movie is interested? No. But people go, and sometimes people start. My husband's Jewish. He says Vorspeise. He eats a little bit. Oh, I'm the one that eats a little bit. He can go on. Do we go? Oh, we got to stop eating. No, keep going. I'll cheer you on. Are you getting my thing for sex? You can stop and say, thank you, keep going. I'll cheer you on. That is a competent person. I'm always grateful for that little deaf boy who got me into a field that I would never have this communication, probably, or compassion as well. All right, can I have orgasms, ejaculation? How about tired? In the morning, how many of you are morning people? Yeah, see, not so many. How many of you are afternoon people? Matinees. I get it, all right. How many of you are night people? Now, if a morning person is coupled with a night person, then now you got to see what's going to work with that. Bowel and bladder. We got those issues during sex. And also, should I tell a potential partner and when? Can I get pregnant for some people? And how will my partner feel if I suggest something? This is what I know about me. Like when you go to a restaurant, I want this, without this, without this, without this. I want this done to my hair without this, like this. This is about me. And now this is called body mapping. I want to ask you something. I want you to think about, not sex. I'm going to ask the women particularly because remember, they got the smaller, wavering, thicker, but I'm going to ask women in this group. Tell me, don't think sex, think relax. Relax. What part of your body would you like to be touched just for relaxing? Anybody? Feet. Who are the feet people? Wait, I'm going to come out. I know he says I have to hold this, but I have to open this. I have to get this out. Okay. All right, feet people. Who are the feet? I got to come down. Got to watch where I'm going. Yeah, I only fell off a stage once. Okay, all right, so here it goes. Okay, all right, here. Who said feet? You did. Man, if I were your partner, I would be feeding you and then backing off. You want your partner to know more. You want to I call this arousal. This is called marinating the meat. So take this water-based lube. You wouldn't throw the steak on without marinating unless, okay, who said feet? Who said, yeah, come on, raise your hand. You're going to take some of these with you, okay? All right, but not every woman's a foot person. Tell me, who else? You, feet. But who else? Not everybody's a foot person. Oh, here. Come on. Say it again. Back. Anybody back? Back. She's a back person. I'd be backing you and backing off. And I would always start in sex with your back. This is called body mapping. And smart people learn their partners and not try and change them. They go back. How many of you are hair and face? Come on. My mother, God bless her, she said, oh, Marilyn, public hair or private hair? Okay, all right, okay. God bless her. She came a long way, born in 1910, my mother. See, I feel better being down here. So the interesting part of this is, how many of you are face people? See, that could be days of hair and face and back. I'm going to tell you one of the couples that came to me. One had MS and she said, I'm a face person. And I go, okay. And she and her partner learned face every day. Face. And then she got to want a little more. Face. They had a joke. Face before head. You know what I'm talking about? Okay, all right, okay. So the interesting part, and by the way, if this minister's kid can do this, anybody can. What I'm doing is called honoring your sex response with the changes. I have to do it with a little infotainment because we're getting ready to go to the U to win. Okay, unless some of you are not to the U. Okay, all right, here we go. So there were many sex tips with MS, and I have a lot of resources so here's the Pillar Company. One has MS or both, and they're going to their sex therapist. And you want to go to some people who know about this. All right, I don't want you to have to pay money of people who don't know about it. All right, and you got Google. All right, you got direct changes, indirect changes, interactive changes. I'm not going to read this all. You can have it. I'll send it to you. All right, and you can see these: loss of drive, erections, vasocongestion, decreased sensation. All right, we saw bowel bladder. We saw fatigue, spasticity. The worst thing is you're enjoying something and you get that what? Spastic. Yes. Cramp. Yes. Oh my God. Oh my God, stop. Okay, now that can interrupt. Now you got a choice. Do you stop completely? Or do you go to plan B and go, okay, let's do something else? All right? And that's a comfortable and common, which I can't imagine you've gotten this far living with MS without knowing plan Bs, right? You are the expert. And I'm only asking people that you add on to it those sexual things. And it's okay to ask and not be perfect, just accountable. Attention. Oh, how many of you might start wanting to have sex and going, this is too much work? We got him. Was that a 10? That's a 10. Good. You keep me up. Well, there would be people who might think you're a 10 for sure. Okay, all right here. So we have these tertiary things, anything psychogenic, cultural. If you came from, I came from a culture that said that it was nasty. Why would something, and then religious, God gives you this. That was so oxymoronic for me. It's like, how could we not honor, but also have boundaries? How could we, I'm doing this, not this. And I'm grateful, and I want to say something. I'm grateful to everybody who had body changes and any kind of diseases or different abilities, because it helped my husband and me tremendously. He had his first heart attack at 47. He has 5 stents in his heart. I learned from you. Yeah, there were the docs, but I learned from you about Plan B. And we stand on your shoulders. And so I'm very, very, very grateful. I have to say that. Stress? Oh, how many of us have stress? Oh, look, here's how they coped. Come on. How's she coping? How's she coping? Well, she's eating ice cream. Okay, all right. How's he coping? He's on the computer. We don't know if he's working or if he's, yes. Oh, the cameras. Oh, man, I know, these cameras. I know, because I'm a person who works the crowd in there. Okay, all right. So he may need to go to fantasy. And by the way, fantasy sex and what we call compulsive sex or sex addiction, it doesn't mean you have a lot of sex. It means it's escape. It means I'm having difficulty and I need to escape. And so there are people who are absolutely skilled in that. Okay, I'll come around and throw these out at the end of this. Okay, so that's good. All right, here we go. Let's see if this works. Okay, so here are the real experts. Expectations of dating. When do I disclose? Do I go to, is there an MS dating site? I'm just curious, because at the last group that I was at, a cancer group, there are cancer dating sites.
There are MS dating sites.
Say it again?
There are MS dating sites.
Excellent. All right. See if you have an option when you don't want to. Thank you. Right here. Go to this gentleman right here. Right here. He knows about that. That's good. Maybe his partner is not so happy with that. Okay. All right. Okay. Here we go. All right. And so I'm glad. I'm very glad. And other people don't want to disclose right away. Body image. How we feel about our bodies. And they do change in many ways. Rejection. I have a question. How many of you are in business, worked in business, have your own business? How many times have you been rejected? Many. Do I have to do something different?
You have to go on stage because the lights are.
Oh, I have to go on stage. Oh, I get it. Oh my gosh. Oh man, oh man, oh man. Oh, look at this. Oh, rules. You're talking to... I'm the Plan B woman from way back, okay? So, but I'm trying to work with you. Okay, here we go. All right, so fear of rejection. How many of you have been rejected? Yes. Rejection doesn't mean no to me. Rejection could mean not this time, not now, especially if you're really looking at that. Balance. Oh, my gosh. Mobility, adapting to walker and chair. I can't even tell you how many people have made love in a wheelchair. In the shower. Marilyn, by the time we get out, by the time we help somebody take off clothes, by the time we help to transfer people. I was with a VA hospital with working with a lot of people, and I'm thinking of her name, Dr. Helen, and I'll think of her name. Here it is. It's very much easier. You want to go for efficiency. And so I learned a lot of people made love in a wheelchair in the shower. That is smart, I think. So the interesting thing is how to be efficient and still connect. Some people don't like shower. Okay, so the interesting thing is communication. What do you like? I liked this. Not so much today. Do you want to change anything? I was really cold. It was really painful. But I like this. You always want to say what you liked, what you want to add on. Any times of privacy, if you have some people help you, there are some people who help actually to put condoms on people. Attendance. If people don't have small motor coordination, just like they would put bibs on people or underwear on people. And there's a lot of myths about MS that you all live with. And then if we have the minorities within LGBT communities, as we get older, gay, lesbian, bisexual, transgender, gender neutral, okay? So here is the worst question to ask after sex. Did you like it? Was I great? What's the problem with this? What are the only two answers? Yes and the best. Because my mama said if you didn't have anything nice to say, you don't say it. So I learned this wasn't so great because the feelings are you get trapped, and then what do you feel? When you get trapped, what did I do to that little boy, 9-year-old Brian? Lied. The best. And then, the worst. Okay, so the interesting part is this is a much better but scarier sometimes. What did you like about any of those 8 types of intimacy? What didn't you like? Just like, what do I like about this medicine? What don't I like? What would we change? The timing, or when, or what do I do this, the food I eat with it? What would you change if we did this again? What would be the scariest answer to what would you change? You. I know. And a lot of people come and say, but many people who've been in long-term relationships go through what I call the decades, and they come out. Oh, by the way, there's your hypothalamus. Larger in boy babies, all right? There's the pituitary gland, just to show you a little bit of this. Oh, I'm sorry, that's one of my patients. Yep. All right, one of my patients, okay. And of course the spine, and you could see bowel and bladder, so if there ever was. I had an L4 radiculopathy once, and I was writhing on the floor, constant pain. And I'm not a drug user, but it took steroids to really stop it. And morphine, but I couldn't live on morphine. And you can't live on steroids too much. But it's interesting, I learned about at that time. Do you see where the sex part is? Yes. See where it's at? On the bottom, the S ones. See that? But now you have to put it with those 6 steps in sex response. Remember that we did, honoring our sex response. Okay, so we talked about the Holy Grail. There's your prostate. We talked about, and by the way, Viagra doesn't work with everybody. It doesn't, or Cialis. You don't see them on TV anymore. You know why? Because the copyright has run out, and now you can get a generic brand. That's why. Okay, but it doesn't work with anybody. And by the way, what does Viagra or Cialis do? It vasodilates. We got to stop pretty soon. And they're telling me now, so really fast. Vasodilates your face and everything else. This is not a bad picture. This is honoring your vulva and what happens with stimulation, pain or not, inside or out. And I've had women who say all kinds about it. This is honoring your body. And this is the inside. See the bladder? Yeah, 1 or 2 fingers in the vagina. Some women say, I have to have toys now, because my neurology has changed. I have to have my favorite husband, she said, and my favorite toy in sex, the pocket rocket. So they worked it out. And they communicated. So here we are. Psychogenic, reflexogenic, parasympathetic, you can see sympathetic, you can see all of that. So ready for good news? Your sensuousness comes in the way. Thoughts, fantasies, sights, smells. All of these people with MS have told me, I'm feeling this today. I'd like a little of this, not this. Could we talk? And by the way, sometimes there are women who don't have orgasms or with a toy, or just on the outside of the body, not the inside. We're all so different. But coming out of your shell takes a while. This is the old sex response that said you had a high desire, plateau orgasms. And these are the 2 that change the face of it. On your left, Laura Berman, sex therapist. On your right, Jennifer Berman, urologist. Don't you think their parents are proud? And here, watch here, everybody. Remember this sex response cycle? They change the face of it. That is the new sex response cycle. International Sexology for the study of women and men's sexual response. Tell me about what it says, top right, before we end here. Sexual neutrality. You want to get it on? Do you feel hot? No, not really, but I'll snuggle and hold and give some of that face or head. Okay, here we go. 5 types of touches. Observation, play, nurturing, sexual, sensual. Eve's Garden, there's the toys. And, yep, toys. Oh, look. if you go to this Enjoy Me and you put MV69, they picked it, not me, MV60, they picked it. You can get a discount, I am told. All right, be careful about too much alcohol, can turn it up. Be careful of fear of failure, depression, sexual pharmacology, and sometimes if the antidepressant is too strong, we deal with a number of things. Lots of reasons for a sex problem. There's the G-spot, good vibrations. These are all suggestions by people. This is vaginismus. Ouch, it's gonna hurt. So you got outer course, or you can use Soul Source. A lot of women do use Soul Source. This is something weird. I just want to end here. Something weird. This was put out for women with neurologic problems, and it pulled the blood down. What does it look like to you? Little mouse, little toilet seat, but it actually works for some women. So I'm just saying, be careful what you put in. Via cream, be careful. It has some chemicals that may or may not help. This is going to be helpful for some men. It's called the vacuum device. It helps. You don't have sex with that plastic thing. You take it off. And that's what's called a Venus O retention ring, but most people say cock ring, okay? And it's a threefer, actually, can keep the erection, the guy won't ejaculate, and if you need a condom, there for sure. This is how my husband gets an erection. He has to put a shot in his penis, nothing else works. And papaverine registine, pretty cool, can last for about an hour. I'll take 10 minutes, that's it. Okay, happy. Okay, and in extreme cases, but there are people who've had penile implants, all right, where there's the 2 shafts and the pump and the saline solution, and he gets an erection for life if he wants it, but he won't usually ejaculate. So here it is at the end. Take care of yourself. Find the best time. Adjust expectations. Turn off or turn on what's going to help. Show what you like. Don't expect your partner to read their mind. They're going to read their own mind. And let sex be human. All right? What did I like? What didn't I like? Watch when meds work. Watch what meds get in the way. Sex is not a track meet. Remember those 5 touches, the 8 types of intimacy? Oh yeah, and as we're getting older, jokes. I said I got a cute angina. Okay, all right, okay. So a lot of people are saying, still doing it over 60. And a lot of people still hug and kiss and hold and touch and touch and touch and be close. Ladies and gentlemen and intersexuals, I wish you many blessings in your intimacy. Thank you, thank you, thank you, thank you. Let's all be safe out there. Thank you, thank you. Coming to the end of all of this, there you go. Right here. Can I just end with this? A stiff penis does not mean a solid relationship. Urinary incontinence does not mean genital incontinence. Absence of sensation does not mean absence of feeling. Inability to move does not mean inability to please, and the presence of any deformities does not mean the absence of desire. Inability to perform does not mean inability to enjoy from my husband and I. Loss of genitals does not mean loss of sexuality. Thank you. Happy sexuality. Thank you, thank you, thank you. Yeah, while I throw things out.
You gotta stay where you are.
I gotta stay where I am.
You have to stay where you are.
Maybe I have some helpers. Is anybody willing to throw things out?
So now the question is, who has a question?
Or you can text me, because some of
So there's a person with the name Rabbit in the back of the room. She's actually Bunny.
Thank you, IT person.
Marilyn, I wanted to add something to your comment that nothing works better than moisturizers, because I just heard a gynecologist say there's something even better, and that is you go to the dollar store, you buy the little mini ice cube tray, you half fill it with coconut oil. When you want to have intercourse, you take out the little piece of coconut oil, roll it between your fingers, use it like a suppository, which does not mean your rectum, and it will work better than any moisturizer.
Yes, a lot of people actually are finding, some people are finding that in the cancer group, support group for women, they were talking about some of the oils, and some women had to put it with water and oil because the direct oil was too much. But yes, thank you, mwah, mwah, to you. Yes. Yes, very fine. That's great. And so you find what works the best for you. That's exactly. That's
Any other questions?
By the way, we're looking at, to speak to this, I was at a conference where they're looking at, can they put something together that are not just water-based lube or not just straight oil? Could there be something in between? So thank you. It's only when we speak up. Thank you. Anybody else?
Things that slide. 1 minute.
Do you have any videos?
Do I have any what?
Videos.
Oh, videos. Oh, well, actually, yes. Yeah, not on me, okay, but there's videos that are called I have to get it right, not smart sex, sexsmartvideos.com. And a number of them have a lot of people who are looking at Plan B, sexsmartvideos.com. And they're educational videos. They have some boring talking heads like me. And then they have real people who are showing and ideas that was just given to us. Exactly. But those are the ones. But some people look at adult films and they're fine. Usually there aren't people with MS on the adult videos unless has somebody found adult film videos. Okay? I always like to find, if you find any that you find helpful, please take a card and email me and let me know, because I want to be sure that I also, questions. These are a lot of, by the way, I want to give a shout out to Michael Barrett, because Michael was the first, years and years and years ago, from Canada, MS Society, who really wrote about when it was really silent before a lot of things on. So there's a lot of good resources for you. But yes, smartsexvideos.com.
I don't see any other questions out here.
There.
Any questions?
Thank you. They're
Thank
ready
you very
to go.
much. I want to give you your certificate, please.
Oh, and
Before everybody leaves, and before everybody leaves, please know that we need you to turn in your seminar evaluation forms to Jennifer or Maria or Anna. They're all over out by these doors. But if you don't mind hanging around and waiting a moment here.
Yes. Oh, pay attention. Pay attention.
Marilyn, Volker, this is a certificate of appreciation. We greatly thank you for speaking here today, and we look forward to more lengthened discussions.
Lengthened discussions. Oh, don't you? I want to thank you all.